Sabitra. We should invite the next speaker, and Dr. Kaushik Murali. He'll talk about integrated people-centered eye care to achieve universal eye health. Dr. Kaushik is President of Medical Administration, Quality and Education in Sankara Eye Foundation.
Thank you so much, sir. I think grateful to the people who are staying on in the hall for the pretty much the last session of the conference. What I'm going to be sharing is about people-centered care and how you actually go about it. So this is a little creative that talks about what does it mean by being people-centered or in terms of general healthcare. So at the center is the person, he has his immediate family, the community, and we need to see how we can be universal, equitable, people-centered, which includes service delivery. The health sector has to be there, and you need many other sectors, right from education to the sanitation, labor, housing, environment, to enable this kind of a people-centered healthcare when you look at health services. I'm going to be sharing some of our experiences at Shankara, where we've tried to ensure that eye health is not defined by where the person lives. So over the last 4 decades, we've made sure that we've had about 30,000 odd screening camps. We've screened near about 6 million population and done about 2.2 million surgeries to the underprivileged free of cost. So that is one facet of care that we've done by bridging outreach camps, having vision centers, as well as enabling hospital-based services. Like Dr. Rohit mentioned, one of the key highlights of the World Health Assembly in 2020 was the passing of the resolution, which mentioned about integrated people-centered eye care, including preventable vision impairment and blindness. So this requested WHO to develop a guidance on evidence-based, cost-effective eye care intervention and approaches to facilitate the integration of eye health into universal health coverage. Now, this sounds very fancy, it sounds very idealistic, but they've actually gone ahead and done a lot on that. What do we mean by integrated people-centered eye care? So, to break it down, it is services that are managed and delivered so that people receive a continuum of healthcare intervention. So, it's not just a one-off event. It covers promotion, prevention, treatment, and rehabilitation to address the complete spectrum of eye conditions according to their needs, coordinated across different levels and site of care within and beyond the health sector. And what it critically does is it recognizes people as participants as well as beneficiaries of these services throughout their life course. Again, we keep using these fancy terms, quite often not even understanding what we are expected to do as operating doctors or being part of the healthcare system. So what do we mean by integrated? Integrated means it's a package of interventions for a particular group. It includes a range of services that is provided at a location so the person doesn't have to keep going from one place to the other. It includes continuity of care over time, referrals between different systems. So you don't need to do it, but you should know where to refer. And you need to be working across sectors to make sure that there is completeness in it. This again is a creative that was shared as a part of the WHO document, which talks about how you can have a continuity of care right from the community to the secondary and the tertiary care. And it again straddles across from screening, clinical examination, treatment, and rehabilitation. So when you look at this one particular thing, you know that at every level there is a play possible, how eye care could actually be integrated into the existing healthcare system. And that makes our role very, very important as ophthalmologists or eye care professionals or from the non-profit NGOs that are working in various facets of this to enable this to happen. I will draw on our experience of our pediatric program called Nanakannu that we launched in Bangalore, supported by Sightsavers then, which had a very clear philosophy of saying that no child, and we define child as from newborn to 18 years, should be needlessly blind, and those with irreversible blindness or low vision should have the same rights and access to services. At that point in time, honestly, we didn't understand what this meant. Advocacy was a term that was pretty much thrust on us by Elizabeth, who was then the director. So we kept fighting with her saying, what advocacy will we do? Let's go operate and get these children treated. But slowly over a period of time, we've understood how critical that aspect is for us to drive policy and intervention and change. So again, when you look at creating an enabling environment, the first step, Dr. Rohit mentioned about the guide. So there are 4 documents that are available on the IFPB site, which is a pretty much an SOP. You can just go and implement and figure out what has to be done. The 4 key pillars are about empowering, engaging people, reorienting the model of care, strengthening governance and accountability, and coordinating services across within and across the sectors. So again, when we talk, let's look at each one of this. When you talk of empowering and engaging community, you're looking at increasing the demand of eye care, including rehabilitation, encouraging timely and appropriate health-seeking behavior, and increasing access via community-based approaches, telehealth. So COVID has taught us that a lot of things can be done with technology. Again, I draw on what we've done in terms of advocacy, in terms of creating demand. So we've done the walkathons, we've done various advocacy events. We put up the world's largest vision chart on a building that was under construction. So this kind of makes people start discussing about eye health. So not just about looking at it. When you look at the human angle of enabling manpower, again, we've drawn on a tiered system where we use volunteer teachers as screeners. So a 90-minute session allows them to understand how it has to be done. And with a key informant method, this is very, very effective. Reorienting the model puts emphasis on primary care. It facilitates level of care from promotion to rehabilitation, timeliness in diagnosis, and the most critical part that we often forget in large community interventions is we look at quantity over quality. But here monitoring is very critical and affordability and access is again very critical. So again, we've looked at the tiered screening model where we said that, okay, we're using teachers, but are they effective? Again, we found them to be extremely good in picking up. So they had a sensitivity of almost 100%. Specificity was very, very high. And referral rates were also very good. So in any of these, you need to be clear saying that how do you measure effectiveness? And if more than 10% are referred, probably you're overdoing it. If it's less than 40% are being picked up, then maybe the training needs to be relooked at. The third pillar looked at coordinating services, where we said that you need to ensure continuity of care and patient-centered care, coordinate eye health within the healthcare, looking at neonates, non-communicable diseases, and occupational health, reframe it so that it is contributing to the sustainable development goal, and work across sectors and ministries. This again is a little video of how we worked with the corporate to make sure that we are able to deliver this. Again, we've worked with Sarva Siksha Abhiyan. So this kind of puts together a model of us being able to take the clinic to the community.
The entire vehicle comprises of what we use in the hospital. It's a mini OPD. All the facilities that are present in our hospital have been installed inside. The instruments we have, firstly we have a lensometer, which will give us the power of the spectacle already being used by the patient. The second is an autorefractometer to give us an automatic read up or a printout of the patient's refractive error. Then we have a trial lens set consisting of all the possible lens powers which we use for trial and error method. A slit lamp biomicroscope, then a direct ophthalmoscope to see the retina, and the fundus camera which can be captured on an iPhone.
So this kind of is possible today and we can push it out. The last bit is about creating an enabling environment where you enhance it by integrating it in health strategies. I think Vision 2020 and many of the stalwarts here have been doing that and making sure that we get that visibility in terms of the plans that are being done. Then you need regulation, you need to prioritize investment. Again, you look at the health budgets, eye care does not get what it deserves. Despite us having a national program for 30 years, you probably have somebody who's wearing two hats and they don't care about eye health, unfortunately. We also need to look at quality control and accreditation and also look at health information. Again, in terms of building manpower, we've had our own academy where we've been training the entire spectrum of students. That kind of becomes very critical when you're looking at developing your own, nurturing your talent. Again, the documents talk of indicators. Again, what I found was this looks largely at cataract and refractive errors. Like Dr. Rohit mentioned, those are the agendas. So these are measures which every institution probably should start recording. And that will help us understand where we are moving the needle in terms of where we should be and where we currently are. My last video is again to reiterate why we do what we do. And, sorry.
ಬೋರ್ಡಲ್ಲಿ ಏನು ಕಾಣಿಸ್ತಾನೆ ಇರಲಿಲ್ಲ ನನಗೆ. ನಾನು ನನ್ನ ಫ್ರೆಂಡ್ ಬುಕ್ನ ನೋಡ್ಕೊಂಡು ಕಾಪಿ ಮಾಡ್ತಾ ಇದ್ದೆ ಸರ್. ಒಂದಿನ ಕ್ಲಾಸಲ್ಲಿ ಟೀಚರು ಕಣ್ಣಿಗೆ ಟೆಸ್ಟ್ ಮಾಡಿಸಿದ್ರು ಸರ್. ಹಿಂಗೆ ಒಂದು ಕಣ್ಣು ಮುಚ್ಚಿಬಿಟ್ಟು ಇನ್ನೊಂದು ಕಣ್ಣು ತೆಗೆದ್ಬಿಟ್ಟು ನೋಡಕ್ ಹೇಳಿದ್ರು. ಅದರಲ್ಲಿ ನನಗೇನು ಕಾಣಿಸ್ತಾನೆ ಇರಲಿಲ್ಲ. ನಮ್ಮ ಟೀಚರ್ ಹೇಳಿದ್ರು ನನ್ನ ಕಣ್ಣಲ್ಲಿ ಏನೋ ಪ್ರಾಬ್ಲಮ್ ಇದೆ ಅಂತ. ಇನ್ನೊಂದು ದಿವಸ ನಮ್ಮ ಸ್ಕೂಲ್ಗೆ ಶಂಕರ ಹಾಸ್ಪಿಟಲಿಂದ ಡಾಕ್ಟರ್ಸ್ ಬಂದಿದ್ರು. ಅವರು ಹಿಂಗೆ ಕಣ್ಣಿಗೆಲ್ಲ ಟಾರ್ಚ್ ಬಿಟ್ಟು ಮತ್ತೆ ಅದೇ ಅಕ್ಷರಗಳನ್ನ ಓದಕ್ ಹೇಳಿದ್ರು. ಡಾಕ್ಟರ್ ಹೇಳಿದ್ರು ನನ್ಗೆ ಕನ್ನಡಕ ಕೊಡ್ಲೇಬೇಕು ಅಂತ. ಒಂದು ಬಾಕ್ಸಲ್ಲಿ ಫುಲ್ಲು ಕನ್ನಡಕ ತೋರಿಸಿದ್ರು. ಇದರಲ್ಲಿ ಯಾವ್ದು ಬೇಕಾದ್ರೂ ತಗೋ ಅಂತ ಹೇಳಿದ್ರು. ನನಗೆ ಈ ಕಲರ್ ಇಷ್ಟ ಆಯ್ತು, ಅದಕ್ಕೆ ನಾನು ಇದೇ ತಗೊಂಡ್ಬಿಟ್ಟೆ. ಕನ್ನಡಕ ಹಾಕ್ದಾಗಿಂದ ಬೋರ್ಡಲ್ಲಿರೋ ಅಕ್ಷರಗಳೆಲ್ಲ ಫುಲ್ ಕ್ಲಿಯರ್ ಆಗಿ ಕಾಣಿಸುತ್ತೆ. ಈಗ ಕ್ಲಾಸಲ್ಲಿ ನಾನು ಎಲ್ಲಿ ಬೇಕಾದ್ರೂ ಕೂತ್ಕೋಬಹುದು. ನನ್ನ ಹೆಸರು ನಂದಿನಿ. ನಾನು ಚಾಮರಾಜನಗರದ ಗೌರ್ಮೆಂಟ್ ಸ್ಕೂಲ್ನಲ್ಲಿ ಓದ್ತಾ ಇದ್ದೀನಿ.
So I think it is very important for us to remember why we are here and what we do and keep at it, because end of the day we want every Indian to see the rainbow. Thank you so much.
Thank you, Kaushik. In fact, you have highlighted the IPC and also you are able to show it very clearly how Shankar Eye Foundation able to integrate this into their model. Thank you very much.